Stacy Lerner, and I am doing my second clinical case presentation. So some background: 32-year-old female, Hispanic, urban setting, Chicago, Illinois, private insurance. The chief complaint: I just found out that I'm pregnant and want you to do an ultrasound. So the reason why I wanted to pick this clinical presentation, I used to be a fertility nurse, so I was super excited to meet this patient and talk about fertility and really educating her and her husband, as well as my preceptor, because she felt like she didn't really have a good knowledge of fertility herself. So that was kind of cool for me to be able to be in my element and talk about something I really, really love and am passionate about. 32-year-old female presents with positive pregnancy test as of 1 week ago. Patient states she does not know her last menstrual period because she's irregular and has been trying for a year to get pregnant. Patient denies keeping track of her ovulation and states that she gave up after 2 months because she was not consistent. Patient is very concerned that she has gonorrhea and chlamydia. Patient requests getting tested because she does not want anything harming her baby. Denies any other past or current partners other than her husband. She also states that she had a history of bacterial vaginosis but no STIs. Patient denies allergies. Denies activity change, appetite change, chills, diaphoresis, fever, unexpected weight gain. Denies change in hair, skin, or nails. Denies headache, sinus pain, facial pain. Denies change in vision, blurry vision, eye pain. Denies tinnitus, pain, and drainage. Denies drainage, congestion, lesions, tenderness, or trauma. Denies hoarseness, sore throat, edema, difficulty swallowing. Denies neck stiffness, edema, or range of motion limitations, and neck pain. Denies chest pain, palpitations, peripheral edema. Denies shortness of breath, cough, chest tightness, wheezing. Denies constipation, anorexia, gas pain, nausea, vomiting, diarrhea, and bloating. Denies bladder spasm, flank pain, costovertebral tenderness, hematuria, vaginal discharge. Denies pain with urination, abdominal discomfort, frequency or urgency. Denies excessive thirst, hunger, urination. Denies heat or cold intolerance. Denies bleeding, bruising, blood clots, or history of blood transfusions. Denies tenderness, swelling, or joints or muscles. Denies peripheral edema, leg, calf pain, numbness, or tingling in extremities. Denies dizziness, gait or balance issues, and speech or motor problems. Denies confusion, cognition problems, numbness or tingling. Denies rashes or lesions, excessive diaphoresis or dryness, or color changes. Denies anxiety, diaphoretic mood, and sleep disturbance, racing thoughts, agitation or nervousness. Denies suicidal thoughts, thoughts of self-harm or harming others. Denies delusions, hallucinations, mood swings, change in appetite, drug use, panic attacks, obsessive or compulsive thoughts, thoughts of dying, disorientation. So past medical history, like I said, was the bacterial vaginosis and PCOS. Past surgical history, cyst removal. So some background: a lot of PCOS patients, which is polycystic ovarian syndrome, a lot of these patients come into a fertility clinic and say, I've been trying for a year to get pregnant, I don't understand. And then when you ask them, are you getting normal periods? And they tell you, no, I'm not. Well, if a patient is not getting a period, they are not ovulating. Thus, they can't get pregnant. And you'd be surprised, a lot of patients don't realize this. So it's just a lot of educating. So the fact that this patient had PCOS and no fertility help is pretty amazing. However, it is difficult that we didn't know where she was in her cycle because she's not regular. Allergies, no known allergies. Medications, no current medications. Denies over-the-counter medication use. Denies ever smoking. Denies alcohol. Denies history of illicit drug use. Denies current work. She lives with her husband in downtown Chicago. He was actually an MD at the University of Chicago in the emergency department. Family history, she only told us that her father had hypertension. Vital signs, 98.7, 120/80, heart rate 68, respirations 15, oxygen 99, height 5'1", weight 125. She was well-developed, well-groomed, alert-oriented, appropriate female, and no distress. Normocephalic, temporal artery soft, non-tender, with no bruits. Bilateral tympanic membranes or pearly gray with coat of light. No arrhythmia, bulging or retractions noted. Bilaterally, bony landmarks are visible. The ear canals are free from drainage. Pupils are equal, round, and reactive to light and accommodation. Sclera anecteric, no drainage or edema. Bilateral eyes. Oral mucosa is moist. No pharyngeal edema or arrhythmia present. Uvula is midline and tonsils are +1 bilaterally. Tonsils free from exudate. Nose is symmetrical. No edema of the nasal mucosa. Narrows patent bilaterally. Neck supple. No cervical lymphadenopathy. No thyromegaly. No jugular vein distension. Respirations even, unlabored. Symmetrical. Chest wall expansion. No chest wall tenderness. Lung sounds clear bilaterally. And no adventitious lung sounds. No cyanosis or clubbing of the fingers. Heart rate and rhythm regular. Apical pulse palpable and auscultated. No gallops, rubs, murmurs, or extra heart sounds. S1 and S2 present and appropriate. No thrills or brutes present. No generalized or lower extremity edema. Active range of motion in all joints. No tenderness at any joints. No deformities or abnormalities. Full range of motion of neck. Abdomen is soft and tender. No masses, guarding, rebound tenderness, or organomegaly. Bowel sounds present in all 4 quadrants. Skin pink, clean, and dry. No rashes or abnormalities present. No scars. Alert, oriented. Gait steady, balance intact. Facial movements intact. Eye range of motion intact. Tongue midline, move side to side without deviation. Speech clearing and cognition intact. No gross defects noted. Affect appropriate. No unexpected distress noted. So some labs. So I ordered a beta lab test and a gonorrhea and chlamydia urine test specifically requested by the patient. That wouldn't be, normally I would tell her to go to her OBGYN to do an entire panel, and they have a specific set of labs that they like to do when a patient is either trying to get pregnant or is pregnant. So normally I would have them do that, but she was so nervous about this for some reason, I just wanted to provide her with some ease. So differential diagnosis, positive pregnancy test or early pregnancy. I put positive pregnancy test. So some of my game plans: patient to have blood taken to check the beta level, to see if it is increasing appropriately, and to return in 48 hours for another level. I'll get to this more as we go. Urine taken to check gonorrhea and chlamydia, and patient is to make an appointment with her OBGYN to establish care. This is very important. I wanted to educate this patient that she wanted an ultrasound done, but most likely it was way too early to even see anything. When I was in fertility, we were watching these patients, obviously very, very closely, monitored them very, very closely. I was calling them every single day with lab results and telling them where they were in their cycle based on their estrogen and progesterone. When they would come back for a pregnancy test, we would act like that was week 4 of pregnancy, and based on their level, if they were positive, if the beta level was above a certain range, we liked it above 20. We really liked it above 50. But we would have them return and do another beta test, and we were hoping to see that number double or more than double. So that's kind of why I wanted her to come back in 48 hours. But anyway, so back to the ultrasound. As we explained to our patients that a gestational sac or heartbeat can probably be seen by 6 weeks, but normally when you go to an OBGYN, we wouldn't send you there until 8 to 10 weeks for an ultrasound. So since she doesn't know her last period, we're really going to want to know beta, because sometimes that can give us a better idea of how far along she is. We also explained to her that gonorrhea and chlamydia are transferred through sexual intercourse, and if the patient and her husband only had one partner, like they told us, that it's very unlikely. She didn't really understand how to get gonorrhea and chlamydia, so there was a lot of education that needed to be provided. But she understood after we talked about everything, and we answered all of her questions. So beta human chorionic gonadotropin, which is HCG. This is a test that shows the level of the hormone that's released when a woman is pregnant. And what actually is released, or what releases this, is the placenta growing. So it's tested 2 weeks after intercourse in fertility settings to confirm pregnancy, and then taken again in 48 hours to make sure that the level has doubled or is increasing appropriately, like I said before. Patients at home detect this level through the urine test, so that's why when we have them, pee on a stick, it's actually measuring HCG or beta. So this is some of the levels and what week it matches up to. If this level is lower than normal, it can either be incorrect calculation of the last menstrual period, decrease from miscarriage, so sometimes we would watch our patient's beta to make sure it's going down and decreasing appropriately if they had an ectopic or a miscarriage. Or this could be an ectopic pregnancy. Higher than normal multiple pregnancies, molar pregnancy, or incorrect calculation of LMP. So if I saw a really, really high beta, I would kind of get a little concerned because I wouldn't want this to be a molar pregnancy. So that's something that you need to be aware of, and you need to really have a specialist look at these patients if that's the case. When to have an ultrasound, 6 weeks confirms gestational sac and heartbeat, and 8 to 10 weeks when most OBGYNs want to see the patients for ultrasound. These are my references. If you have any questions, I love talking about this, so I'm really happy to share this with you all, and have a good rest of your week.